We're going to start with the first presentation by Pamela Sampson on cardiac radiobiology.
Thank you very much for the opportunity to present cardiac radiobiology to introduce this session. I have no disclosures. The goals of cardiac stereotactic body radiation therapy for ventricular tachycardia is similar to that of catheter ablations. We want to treat the aberrant VT circuit so that it is no longer functional, provide full coverage to the mapped area of the VT circuit, and avoid giving treatment dose to healthy cardiac structures. So the objective of this presentation is to provide an introduction of the radiobiology principles that guide our understanding of this therapy. So rather than depositing heat, the biologic effects of radiation involve ionizations. This begins when incoming high-energy photons, otherwise known as high-energy X-rays, liberate electrons from the matter that it is interacting with in the target. Once these electrons are liberated, it can either go on to directly interact with the DNA and damage it, or it can interact indirectly with a water molecule to produce a hydroxyl radical that is highly reactive, and that can diffuse a short distance to damage the DNA. Since the majority of our tissues are water, most of the damage we see to DNA is actually from this indirect action driven by the hydroxyl radical. It should be noted that this process is actually quite fast and occurs on the order of a picosecond. Deposition of energy from radiation can result in actually a variety of types of DNA damage. Most frequently, it incurs ionizations, sites of base damage, and single-strand DNA breaks. However, our body and our cells are actually quite adept at repairing those types of injuries. More rare are the double-stranded DNA breaks from radiation therapy. While a rare event, this is what is actually largely responsible for cell killing from radiation therapy, as it is quite more challenging to repair double-stranded DNA breaks, and that imparts consequences for daughter chromosomes. Now, usually when people think of radiation therapy, they think of conventionally fractionated radiation therapy, and that's where we give a relatively low dose of radiation daily over a period of 4 to 6 weeks. And the reason for this fractionation schedule and this number of treatments is to take advantage of what we call the 4 classic tenets of radiobiology. The first is that tumor cells, because we're thinking of the perspective of a tumor cell, these cells can repair sublethal damage, so they do need multiple treatments. Radiation therapy will cause cells to redistribute into more radiosensitive phases of the cell cycle, such as mitosis and G2 when DNA is open and more susceptible to injury. Tumor cells can repopulate between fractions, and additionally, as tumors shrink, the hypoxic cores of tumors can become reoxygenated and make them more sensitive to radiation therapy. Considering this, we can think about the radiosensitivity of cardiac tissue from a cardiac perspective. Myocytes, which are post-mitotic cells, are actually very resistant to ionizing radiation. Fibroblasts are resistant, but radiation can actually induce differentiation of those fibroblasts into structures that are actually quite active in collagen production, type 1 and type 3, which can have implications for scar formation. Endothelial cells are relatively radiosensitive, and within hours of radiation, damaged endothelial cells can secrete growth factors that go on to stimulate an inflammatory response. Now let's turn to SBRT. SBRT is delivered with the use of multiple beams or even arcs of beam to a tumor coordinate. This is quite different than the large volumes that we use in conventionally fractionated radiation therapy. What you'll notice in these images is that these multiple beams have an area of convergence that is actually quite high dose. That area of convergence allows a steep drop-off in the area outside of our target. This is what has facilitated the use of SBRT in brain, spine, lung, liver, pancreas, which are also sites of critical anatomy that, if done incorrectly or immobilized incorrectly, can have disastrous consequences. However, when done correctly, it allows ablative doses of radiation to be given while limiting dose to normal structures. So stereotactic body radiation therapy is given over 1 to 5 fractions and is typically greater than 5 gray per fraction. So this is high-dose radiation. But based on that number of fractions, we know that the radiobiology tenets we mentioned earlier in regards to tumor cells wouldn't really be in play here. However, prior oncologic work has shown that the effectiveness of SBRT is a direct function of the biologically effective dose. So as our dose in that area of convergence increases, we get improved tumor control. So in regards to what biology is going on in SBRT that's different than our conventional understanding, the parts of that could be relevant to cardiac SBRT include mechanisms of endothelial cell damage, where after exposure to high-dose radiation, the microvasculature undergoes a wave of apoptosis pretty quickly and then is gradually replaced by fibroblasts that could lay down scar. Additionally, cellular apoptosis would be occurring to the target tissue itself in a dose-dependent manner, and that's aided by the collapse of the microvasculature. So these two processes are occurring in conjunction. In regards to preclinical data for cardiac SBRT, the role of apoptosis has begun to be elucidated by Dr. Lehman and colleagues that demonstrated the presence of apoptotic markers 3 months after heavy ion irradiation in an animal model, 40 gray and 1 fraction to the atrioventricular junction. Interestingly, at 6 months after cardiac SBRT, fibrosis was visualized, but the apoptotic markers were no longer present. Additionally, Dr. Paul Zai and colleagues have demonstrated the dose-response efficacy of SBRT in creating electrical block in the normal pulmonary veins of animal models. Gross specimens of the animals that saw complete clinical effect demonstrated evidence of scar on pathology, while specimens that were treated at lower doses and did not have a clinical effect did not see the scar formation. In regards to human histology after cardiac SBRT, we do have postmortem cardiac samples from a single treated patient that passed away from a stroke 3 weeks after her cardiac SBRT treatment. On those postmortem cardiac samples, we could see a sharp interface between the fibrosis and the targeted area of her prior infarct and the viable myocardium. Interestingly, we did not see any significant edema, hemorrhage, or areas of active inflammation. So while our current understanding of SBRT radiobiology explains some of the effects we expect to see in the heart tissue, the processes described by these preclinical studies occur over the span of months. What remains to be understood, however, is the biology of the rapid clinical effects we see with cardiac SBRT in the days following treatment before full apoptosis and fibrosis would have taken place. Currently, this rapid response to radiation therapy is a very active area of research, with hypotheses including acute vascular changes, edema, possibly changes in gene expression for transporters such as connexins, and direct effects to the autonomic nervous system. Certainly, there are known long-term cardiac toxicities to normal heart structures that we've seen in survivors of lymphoma and breast cancer. That the timing of those toxicities usually take place over a period of 5 to 30 years after the time of treatment. And it's those series that have guided our radiation dose constraints to the heart and contemporary treatment planning. Interestingly, though, radiation oncologists tend to think of the heart as just one structure, and we limit a dose to the heart. But I think especially as we go down this road of cardiac SBRT, we will increasingly need to pay attention to dose to cardiac substructures and particular toxicities that may evolve from those areas. So in conclusion, cardiac SBRT can provide dose resulting in VT circuit ablation without the anatomical constraints that may limit certain types of catheter approaches. Cardiac SBRT also offers very steep dose fall-off compared to conventional radiation therapy, and this is critical for limiting dose to healthy heart tissue. The biology of cardiac SBRT is actively evolving, and we will need to continue to follow these patients closely to monitor for the development of late heart toxicity. Thank you.